Obstetric Anesthesia, Diseases and Pregnancy 2, Hernando de Soto. We're going to talk in this presentation about maternal hemorrhage, especially in the prepartum scenario. Question. A 20-year-old, 39-week pregnant patient presents to the labor and delivery suite with vaginal bleeding. Concerns include: A. Placental abruption bleeding is never concealed. B. Disseminated intravascular coagulation is more likely to develop following placenta previa than placental abruption. C. Hemorrhage is not a leading cause of maternal mortality in tertiary care hospitals. D. Placental abruption is not a common cause of antepartum hemorrhage. E. Placental accreta is more likely in patients with a previous cesarean delivery. The correct answer is E. Placental accreta is more likely in patients with a previous cesarean delivery. A is incorrect since placental abruption is usually concealed. B is also incorrect. Abruption is one of the leading causes of DIC in pregnancy. C is also incorrect since hemorrhage is one of the leading causes of maternal mortality. And D is also incorrect since along with placenta previa it is one of the leading causes. Maternal hemorrhage prepartum. It is the leading cause of maternal death worldwide. 2 to 55% of deliveries are complicated by procedure for prolapse and hemorrhoids. Regional variation is very marked. Characteristically, it's massive and swift. Blood flow to the uterus, late pregnancy, 10% of cardiac output. Hemorrhage, again, may be concealed with usual signs of hypovolemia late or disguised. What about the incidence and causes? Again, happens late in pregnancy, can be due to placental previa, placental abruptio, spontaneous uterine rupture, especially on VBAC patients, disseminated intravascular coagulation due to amniotic fluid embolism, for example, and also in trauma causing maternal hemorrhage. Can happen postpartum due to uterine atony, surgical trauma, patients that develop retained placenta, and again, disseminated intravascular coagulation that can happen postpartum. What about placental previa? Usually it's position of the placenta at or near the cervical os. Incidence occurs 1 in 200. Recurrent in subsequent pregnancy, and the classification can be total, partial, or marginal. These are just schematic representations of partial, complete, and marginal to the right. Diagnosis can be made clinically and with the ultrasound, painless bleeding in the 3rd trimester. And again, the ultrasound is the best way to find the placenta. Obstetric management depends obviously on the gestational age of the fetus, always looking for fetal maturity, presence of active bleeding, fetal condition, and the presence of active labor. Usually, the obstetrical management with a non-obstructing placenta, a trial of labor can be allowed. Although many obstetricians recently, with any kind of placenta previa, they will look for or perform a cesarean section. Again, conservative management, obstetrical management if the fetus is premature and the mother is stable, or labor induction if the fetus is mature and mother is stable, and C-section if either the fetus or the mother is unstable. For us, the anesthetic management for labor epidural, if mother and fetus is stable and there's no coagulopathy. Subarachnoid narcotics only if the mother is moderately hypovolemic and no coagulopathy, and obviously monitoring as appropriate. For C-section, again, if everything is stable and no coagulopathy, epidural is perfectly fine. If it's an emergency, there's no time to place the block, or if there's any form of significant coagulopathy, then general anesthesia is the best way. Obviously, watching for postpartum hemorrhage because the uterus may not contract well. Abruptio placenta, the incidence happens a little bit more frequent than placenta previa. Incidence 1 in 86 to 1 in 200 of pregnancies. Here is mild to severe pain. Usually in the third trimester of pregnancies, 50% occur after 36 weeks. And the recurrence also can be very high in subsequent pregnancies. And this is just a figure with a classification of abruptio placenta here, and external abruptio here, a relatively concealed abruptio, and a concealed abruptio, as you see here, which can be the most difficult to deal with because the patient is not actively bleeding. Risk factors are many. Hypertension, pregnancy-induced hypertension, depending on the setting that you work. Our obstetrical patient population at our place, there's a very high incidence of drug abuse, cocaine abuse, so that is a huge risk factor for our practice. Polyhydramnias, uterine tumors, smoking again, or any form of drug abuse like cocaine, trauma, previous abruptio, multiparity, increased age. So again, many risk factors for abruptio placenta. There's classified into 3 grades. Grade 1, which happens in about 40% of patients, slight vaginal bleeding and some uterine irritability. Usually patients are normotensive, or if there's any variations in hemodynamics, not much. Fibrinogen is normal, so there's coagulation is usually fine, and fetal heart rate pattern is normal. Grade 2, now we have some very significant problems. Bleeding can be mild to moderate. The uterus can be very irritable with possible tetanic contractions. Usually blood pressure, hemodynamics are maintained, but there may be some hemodynamic problems. There is now some coagulation issues, and the fetal heart rate may show some fetal distress. The worst scenario obviously is grade 3, which does not happen very frequently as the other 2 grades, but now bleeding can be severe, may be concealed, very painful tetanic uterus with hemodynamic issues. Fetal death has usually occurred here with significant coagulation problems here. About 10% of them may develop DIC and acute renal failure. Really the only resolution is delivery, and again, differential diagnosis with placental previa. Just a second on disseminated intravascular coagulation. The incidence is about 0.1% of pregnancies. As you see, all the potential causes or the most frequent potential causes of disseminated intravascular coagulation, being at the top of the list there, placental abruption, but some of the others there, including intrauterine fetal death and amniotic fluid embolism. Clinical features: oozing from IV or skin puncture sites and a dramatic decrease in fibrinogen level. Mild abruptio, regional anesthesia is okay, usually not a problem to allow patients to go to labor, but moderate or severe, especially if there's a non-reassuring fetal heart rate tracing, obstetricians will usually declare an emergent cesarean section, usually under general anesthesia. Be prepared for massive hemorrhage, the so-called cuvulaire uterus, which is blood infiltrating the uterus, preventing adequate uterine contractions even following delivery. And surgeons might elect in rare situations to ligate internal iliac artery or to do a hysterectomy. Other issues would avoid high-dose ketamine, prompt use of oxytocin, prostaglandins, and ergots. and beware of the postpartum period. Thank you.